monitoring of the respiratory system. And when you know these slides, since the early 80s, we know that ARDS, and I will focus to ARDS, monitoring of the respiratory system. And when you know these slides, since the early 80s, we know that ARDS, and I will focus to ARDS. I cannot go into the details on muscular function during weaning. It's not a diffuse injury, but it is a heterogeneous one. Consolidations are localized primarily in the dependent lung areas. Lung edema is responsible, or a major responsible thing for these consolidations. And we spend a long time discussing about techniques to recruit these lung units, to improve gas exchange, and at the same time to avoid an injury of the well-aerated areas. You know these discussions. So there are a lot of data indicating that an increase in extravascular lung volume is increasing the non-aerated lung volume observed in the CT, and it's also increasing the interpulmonary shunting and vice versa. But look also on the ITPV, because if it is decreasing or normal and extravascular lung water is increasing, it's indicating a permeability increase. And if the interthoracic blood volume is increased and the extravascular lung water is increased, that means volume overload or a hydrostatic edema. Well, in patients with a cardiac pulmonary edema, there are a lot of data existing that when you do a diuresis, extravascular lung water index is decreasing. And you don't see that by CVP, wedge pressure. It may be a good target to titrate your diuretic therapy. But when you look on patients with ARDS, and we have done that in severe ARDS, fluid restriction or diuresis therapy is decreasing the extravascular lung water, but only to a certain degree, because there is a permeability problem. So in these patients, it is not necessarily your target, but it gives you it's a very good indicator of the risk of the patients, and that has been already demonstrated by several publications. So what is evidence-based? That is more or less what the ARDS network suggests how to ventilate a patient. But I think it's important that you also go into the detail of the pathophysiology. So you know this sketch that is, has been developed by Luciano Gattinoni. You see the collagen and the elastic fibers, and the lung is distended. And at a certain point, the collagen fibers are unfolded. So you have an increase in the strain and the stress, and you have then a sharp increase. And at a certain level, you will have morphological destruction of the lungs. So the stress, that is the transpulmonary pressure, that is the airway pressure minus the pleural pressure. The strain is the tidal volume above the FRC. And both is linked by the specific regional elastance. So in a homogeneous system, you will find a moderate increase of the transpulmonary pressure. But normally we ventilate lungs that have non-ventilated and ventilated lung areas. And then you will find huge increases in stress, meaning transpulmonary pressure. So when you look on a patient with a pulmonary lung injury and you apply an airway pressure, most of this pressure is used to distend the lungs. When you look on a patient with an extrapulmonary lung injury, maybe with an increased abdominal pressure, only part of this airway pressure is used to distend the lungs. The other part is used to distend the thoracic wall. And therefore, the transpulmonary pressure is different in these two patients. Intra-abdominal pressure is a very important determinant for the chest wall elastance, the chest wall compliance. But we have no data that tells you that you have to set a PEEP at a certain level if your intra-abdominal pressure is increased. You apply 30 centimeters of water. If you have a low pleural pressure, the transpulmonary pressure would be 18. If you have a high pleural pressure, because you have an increased intra-abdominal pressure, for example, transpulmonary pressure is 12. You may have more atelectasis formation with less transpulmonary pressure on the one hand. On the other hand, it may be beneficial for your lung because ventilator-induced lung injury may decrease. You have heard already lung volume and pressure in the lungs. You have the sigmoid shape of the compliance curve, non-ventilated lung areas, optimal ventilated lung areas, over-distended lung areas. These things are still standing in textbooks. Also, we know that recruitment and over-distension may occur at the same time. And you will find atelectasis formation and over-distension even in the steep portion of the compliance curve. Well, you may say, I measure the FRC. That's right. That is very interesting. We know that it has a good correlation with the FRC measured by the CT scan, but it measures the accessible gas volume. It measures if you increase the gas volume in the lungs. So if you have a patient with an emphysema and you apply PEEP, it's also increasing the gas volume. FSC alone does not tell you if recruitment is going on or not. Again, coming back to the transpulmonary pressure, Giovanello from Milan has demonstrated that even if you use a protective mechanical ventilation and use different PEEP levels, you have a huge scatter of the transpulmonary pressure. So only restricting airway pressure may not help. So do we need to measure the pleural pressure? Well, we can't measure the pleural pressure directly. We use the esophageal pressure. And the assumption is that the esophageal pressure is giving you the mean pleural pressure. You have to use a balloon catheter technique. You have to place it in the middle third of the esophagus. You have to know the PV characteristics of your balloon. In the supine position, you also measure the weight of the lungs and the mediastinum. You have artifacts, swallowing, vomiting is a problem. And you have to look at the PSV curve. That is very important to know that you have exact positioning. That is what is the problem. The mediastinum is putting some weight on the esophagus. That are the catheters we are using. That is the technique. You think that if you use 60 centimeters, you're in the best position. But you have to look if you have cardiac signs in the curve. That is a positive pressure ventilation. That's spontaneous breathing. You see the decrease in the esophageal pressure. But are there data that that is the technique? New England Journal of Medicine, transpulmonary pressure target 0 to 10 centimeters at end expiration, below 25 at end inspiration. What are the major changes? The major change was the change in the PEEP level. Higher PEEP levels were used in the group that used the esophageal pressure balloon, that used the transpulmonary pressure target, and also they compared only 30 to 31 patients. The 20-day mortality was slightly different, not reaching the level of significance, but still it gives you some hints. So the determination of the transpulmonary pressure, I think, is complex. It varies regionally. We only determine the average. Ventilatory settings targeting the transpulmonary pressure may be favorable, and an easier monitoring technique, that is what we would require. Again, protective mechanical ventilation, you see less atelectasis formation at inspiration, normal aerated lungs, and now again using 6 mL per kilogram body weight, a huge atelectasis formation at end expiration, no recruitment going on, and a lot of red dots indicating overinflation. So the disadvantage of the current measurements is global measurements, no measurement of the absolute FRC. It does not give you information on specific lung regions. Recruitment and overdistension may occur simultaneously. So do we need to use regional ventilation imaging technology? Well, that is what you know, that is the CT, but it's not used at the bedside, so you cannot use it to set your ventilator. That may be possible with the EIT technology, where you look for changes in the impedance, and that is corresponding to ventilation. Electrical conductivity is very important for the EIT technology, and you see that the resistance is different for different tissues in the thorax, and of course the lungs change during during expiration and inspiration. But also the volume, the ion concentration may change, and that is important for the extravascular lung water. And you see Kunst and co-workers have used a spectrometry technique with impedance technology, and were able to measure lung water with this technique. What we do is electrical impedance tomography. We have a pulse with electrodes. There is some processing of the data, and we get this image. You inject the current, and you measure the tension with the other pair of electrodes. We use 16s, others have used 32. And in total, you get about more than 10,000 measurements per second. So that's quite a lot. There are different reconstruction algorithms that are comparable to the construction algorithms used in the CT scanning. They have also used several electrode planes to get more information of the lungs. There are also publications, but when you look at the guanal and more to the caudal electrode belt, you see more information is provided by the caudal belt. And the reason is, when you look on the impedance data, this belt gives you a slice of about 4 to 7 centimeters. 0.5 is the normal slice of the CT. And actually, this caudal part is obviously the part that is interesting for us. What does the image tell us? It shows you the change in the impedance, and the change in impedance is the change in volume, that is ventilation. So expiration, inspiration, and that is how it's looking. So the spatial solution is not as good as in the CT, but it's a good dynamic solution. You see the patient is breathing, and you can not only see the global change in impedance, but also the regional one. And that is an advantage, I would say. Several validation studies have been done, comparing it to the CT, comparing it to single photon emission tomography. And again, also we have done a study comparing it to the computer tomography, and you see quite good results. What information is provided? You see here atelectasis formation due to a pleural effusion. You see atelectasis, recruitment maneuver. You see changes in the end expiratory impedance level. The guys are coming. And the real problem is the interpretation. There have been some improvements showing difference imaging, where you see the gain and the loss of volume that has been already used and published for healthy and diseased patients, that can be seen also in the commercial available devices. There are also the possibility to indicate hyperinflated lung areas. That is very important. And you can calculate the regional compliance using electroimpedance tomography technique. We developed a different way to interpret the data, early or late. And when you look at this data, you see the original EIT, the mapping, and with a peak level of 15 to 20, there's a more homogeneous distribution of ventilation, and that corresponds to the potential for recruitment, and it's also quite well correlating with the cyclic alveolar collapse that is important for the ventilator-induced lung injury. I have to skip the slides, but we have also some data where we tried to set ventilatory settings according to EIT and compared it to the ARTS-NET protocol and the open lung approach. What you here see is not EIT, that are SPECT data giving you ventilation perfusion mapping. You see less formation of atelectasis formation, less formation of dead space, and the future is that we want to see such things because we are also able already to get some information on lung perfusion that is not so easy like ventilation images. We also can use contrast agents like saline or glucose. You can measure the things in the right heart and the left heart. I think they take me down. I'll wait for that. We have done validation studies, and that are the first studies that have been published on the VAQ matching using EIT tomography. So I think this technique has advantages, and all techniques that I described to you today is not evaluated in the clinical side, and I think that is important, and it also tells us what has to be done in the future. So I waited to get down on the stage and nothing happened. So, okay. Thank you very much.